usually used to monitor the HIV positive individuals. Actually, I'll talk about this test in patients newly diagnosed and after ART initiation. I choose to divide them into non-HIV specific tests and HIV specific tests. And the majority of recommendations in my talk today are based on grade A evidence, actually. Some few recommendations in my talk are based on other grades, and I will mention when I come across these recommendations. The first thing to do, if an HIV patient comes to your clinic, if the diagnosis is not confirmed, the first step is to confirm the diagnosis. This will safeguard against sample mix-up or contamination, and it will distinguish between HIV-1 and HIV-2, actually, because the treatment of HIV-2 is substantially different from that of HIV-1. Now, talking about the non-specific routine essential test for the blood count, as you know, anemia, thrombocytopenia might be encountered in HIV patients, in addition to opportunistic infection, so the CBC might give you an idea, and usually it is done concurrently with the Cd4 count while you are following up the patient. Renal profile, including kidney function test, acute kidney injury and chronic kidney disease are common also in patients, especially in advanced HIV patients. And it will help you to appropriately dose the antiretroviral therapy and other medications. Usually we repeat it at 1 month, 3 and 6 months. Then if the patient is not a high risk renal patient, you do it every 6 to 12 months. Liver profile, again, including the bilirubin, ALT/AST, and alkaline phosphatase. Abnormalities in liver function tests are common because of the opportunistic infections and the medications that you use to treat such opportunistic infections. So it is necessary to monitor the liver function test during the follow-up of an HIV patient. Usually we do it at 1 month, at 6 months, or when it is clinically indicated. Random lipid and sugar profile, especially for those who are at an increased cardiovascular risk. Screening for hepatitis A, B, and C is necessary because co-infection with hepatitis amongst HIV patients is common, might reach up to 20% for hepatitis B, and the choice of your ART or antiretroviral therapy is significantly influenced by the presence of hepatitis B or C. It will force you to use some agents that are effective against the hepatitis B at the same time, or hepatitis C. So it's necessary to screen for hepatitis. Screening for TB using interferon gamma release assay is also necessary. We don't use the MAN2 test. We don't rely much on MAN2 test. It might be negative. Even acid fast bacilli might be few, might not be detected in AIDS patients in the sputum samples. So we use the IGRA, and this the screening for TB is usually based on the risk history, especially in people from high prevalence area and in people with low CD4 cells. Obviously, screening for other sexually transmitted diseases is necessary, such as syphilis, gonorrhea, and chlamydia. Cervical cytology is an optional. It's an evidence C. It's not an evidence A. It's an optional. So if you are planning to do it, you do it for women aged between 25 to 65 years, or those who haven't had the cervical cytology ever. Now, moving to the second part, which are HIV specific tests. The first is the Cd4 T-Cell Count. It correlates why it's necessary and significant because it correlates with the level of immune dysfunction and suppression, which in turn determine the urgency of starting ART. As Dr. Michel mentioned, test and treat. So there is the CD4 cell will previously the guidelines were dependent on the CD4 level to determine whether to treat or not. But nowadays, the CD4 level will determine how urgent you need to start your ART. Again, it will help you to guide your chemoprophylaxis for opportunistic infections and whether you are going to use a live attenuated virus or vaccine amongst HIV patients. The CD4 count will help you. The second specific test is the HIV viral load. There are many different assays exist actually with variable detection rate of the viral load. The range is between 20 to 75 copies per mil. If your patient is HIV positive and is having a Cd4 count that is low, but you are unable to detect the viral load in this patient, the first thing to do is to repeat it using a different assay, more sensitive detection rate, and to do the serology again to rule out that this patient might be an HIV-2 patient actually. So the viral load is important. HIV specific test that will help you to monitor the response for ART, antiretroviral therapy. And usually the viral load will decline steadily until the 4th or 6th months. It will become undetectable if the treatment is successful. This actually depends on the initial load, and it depends also on the ART regimen that you are using. But in general, it will decline by the 4th to 6th month to undetectable level. It is recommended to measure the viral load at 1, 3, and 6 months. So at 1, 3, and 6 months from starting the ART, then 6 months, once every 6 months. The third test, HIV specific test, is the resistance testing. A baseline genotype resistant, we use genotype resistant test. Phenotypic resistant testing are not commonly used because they are laborious and they take long time to have the result. So it's basically a genotypic resistant test for protease and reverse transcriptase genes. You do sequencing and you submit the data to a specific database, and you will get the answer about the resistance amongst the virus for these two categories of genes. The fourth test is the Hlab 5701 testing. This test is usually done to identify the patients at risk of abacavir hypersensitivity. Abacavir is known to have a hypersensitivity reaction, just like any other, for example, Septrin, any other ART, some of them, they are having also hypersensitivity reactions, but it was found that some patients who showed hypersensitivity reaction to abacavir were Hlab 5701 positive, and therefore it is necessary to screen for this HLA type before you start abacavir to avoid hypersensitivity reaction. Prevalence of this HLA type is variable. It's more common in white people than black people. It might reach up to 5 or 6% amongst white people, while it is usually 1 to 2% or even less than 1% amongst the black people. And that's all actually. I tried to make it as brief as possible because of time.